Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearscope endoscope, and I have a really interesting case for you guys. So I have a patient who attended with a keratosis obturans, and I will explain what a keratosis obturans is during the course of the video. And I'll just give you the case history. So this patient experienced sudden onset of otalgia, so ear pain, a couple of days ago. And it was so severe that they actually attended accident and emergency, so A&E at their local hospital, who examined their ears and explained that they've got earwax and to use some softening drops. If you attend A&E with an earwax impaction, it's not something they will remove for you. And so they were asked to arrange an appointment with their GP, but the pain got so severe, they did some research, came across me and booked in. And immediately observing this plug, I knew it was Keratosis obturans, not only due to the patient's symptoms. So earache, so otalgia, is one of the hallmark symptoms of Keratosis obturans. Not everyone with earwax suffers ear pain, but to be diagnosed with true Keratosis obturans, there is some sort of pain experienced by this patient. And as soon as I made contact with this plug, I knew it wasn't earwax. Instead, it's an epidermal plug, which is what Keratosis obturans is. So Keratosis obturans is a benign accumulation of dead skin cells that have shed in the ear canal, and they form into a plug. And as I said, it is quite benign. So on the early stages, patients won't exhibit any symptoms. It's just when this plug starts to compress against the canal walls when they realise that they've got something not quite right in the ear. And I always compare the keratin plug, so this epidermal keratin plug in Keratosis obturans, as a rubber ball. And this rubber ball is forever expanding. And this epidermal plug doesn't migrate outwards, it gets trapped deep in the ear on the osseous portion of the ear canal, so the bony region, so the inner 2/3. And there's four grading systems. So grade 1 is when you've got the patient exhibits an occlusion of the ear canal, which is what they've got, pain, and kind of mild conductive hearing loss. But there may not be any discernible widening of the ear canal. Now, with grade 2 Keratosis obturans, the patient again experiences pain, they have a conductive hearing loss, and they have a noticeable widening of the ear canal, and I'll explain how this widening occurs. Grade 3 is similar to grade 2, but in addition, there's some sort of granulation tissue. So granulation tissue is inflammatory cells, typically made up of connective tissue, and they undergo a process of neovascularization, so they have their own blood supply. And you normally find this in the region where the cartilage portion of the ear canal meets the bony part of the ear canal, so the osseous cartilaginous junction, which is about 1/3 of the way into the ear canal. And quite often when you remove the keratin plug, you disrupt all these new blood capillaries and connective tissue, this granulation tissue that's formed, and you get what we call contact bleeding. So the patient bleeds not because we've damaged the ear canal, but we've ruptured these new blood capillaries that are formed as part of the neovascularization process. And grade 4 is this most severe form of Keratosis obturans. Typically, patients with a grade 4 would visit A&E, and they would probably be seen by an ENT on call. And quite often that would need to be removed surgically with the patient under a general anaesthetic. Even a grade 2 or grade 3 or even a grade 1, sometimes the pain is so severe that the patient can't tolerate that even with local anaesthetic, so they have to go under a general anaesthetic to remove. And with a grade 4, this keratin plug starts to invade adjacent structures, so it can grow anteriorly forwards and towards the temporomandibular joint. It can grow backwards to the mastoid bone here, so behind your ear, and form what we call an automastodectomy. So ENT surgeons sometimes perform a procedure where they drill out all the bone, the mastoid bone, if it gets infected, and we call that a mastoidectomy. But when it occurs naturally, so to speak, without any surgery, we call that an automastodectomy, and that can sometimes be the case with the keratosis obturans. I've had one case of keratosis obturans, a grade 4, which I partially treated, but they needed to be seen by an ENT and have surgery for the remainder of the removal. And I didn't realise that I had an automastodectomy until I started removing some of the keratin plug. And it can also grow upwards towards the brain. So there's the bone that separates the intercranial cavity and the middle ear. It's called the tegmen tympani. So you could have a dehiscence. It could start remodeling the bone that separates the skull from the middle ear, basically, and they are your really severe cases. Now, what causes keratosis obturans? So typically it's inflammation of the ear canal, and therefore it's more common in patients below the age of 40, where you would expect there to be more blood flow. So when you have increased blood flow, and we're talking an abnormal amount of blood flow, your ears or skin cells around the body are formed as part of that process, and the more skin that's formed in the ear canal, the more dead skin the ear is eventually going to shed, and this dead skin collects. So that's one primary reason. Another reason for potential keratosis obturans is, if you've been watching my channel for a while, you already heard this, but our ear canal and eardrum is lined with skin. And as this skin begins to die and shed, it moves sideways out of the ear like a conveyor belt. So your ear has evolved to expel dead skin from within the ear canal. If it wasn't able to do that, then this is the end result. So, so therefore, another potential cause of keratosis obturans is the abnormal migration of dead skin. Instead of migrating laterally from the eardrum to the entrance of the ear canal in a conveyor belt motion, the dead skin migrates into the middle, so centrally. So it's an abnormal migration, and it eventually forms into a plug. And then what occurs with this plug, as it grows and grows and grows, the physical pressure, as I said, I made reference to it being like a rubber ball. And the reason why I say it's like a rubber ball, it's so springy, and you'll see it here when I'm trying to lift it off the canal walls. It just wants to spring back, and that in part is due to the kinetic energy this has. So this is literally layers of dead skin. And just to go back to another potential cause of keratosis obturans, as this skin naturally migrates out of the ear, the individual skin cells should separate. The skin that's lining the ear canal now, the epidermis layer, all these squamous skin cells, so these epithelial skin cells are interconnected, they're locked together, and there's multiple layers. You have like 10 to 20, even 30 of these layers of squamous epithelial skin cells. But as the skin begins to die and shed, they should separate from the underneath layer, and the interlocking connections between adjacent skin cells should also separate. So you should get flakes of dead skin. We call that desquamous skin. But with keratosis obturans, not only could it be an abnormal migration of skin, so instead of coming outwards, it's kind of shedding into the middle, but the individual skin cells fail to separate fully. So you get this kind of lamellar structure. It's almost like an onion. You've got these layers of skin, ribbons of skin, which are still interconnected. And the most peripheral layer of skin, it's like a white silvery matrix, and you will see that eventually. So what causes the ear canal to widen with a keratosis obturans? So what causes it to distend and kind of remodel itself? Now, it could just be the sheer pressure of this keratin plug. It's compressing against the bone and forcing the bone outwards. But typically it's because of a process called bony resorption. So all the bone in our body is continuously kind of repairing itself, rejuvenating itself. And that process is called bony resorption. So old bone on the surface of the, whichever part of the bones in the ear canal, the surface bone, there's specialized skin cells there called osteoclasts, and what they do, they break down the outer layers of the most superficial layer of the bone into its kind of core minerals and tissue, and then it redistributes those minerals into the bloodstream, so other bone and other parts of the body can use that to make and utilize it to form new bone. And there's specialized cells called osteoblasts which are involved in the forming of new bone. So basically the bones in our body is continuously repairing and healing itself by almost degrading the most superficial layer and replacing that with some new bone that it can form. So when you've got this keratin plug and it's forced and pushed up against the canal wall, it initiates these osteoclasts, and you get this process occurring, and then you get this bony remodeling, so the ear canal widens. Some of the questions in the past about keratosis obturans, is it possible for some of this bone to kind of regrow during the second phase of bony resorption? So when you got the osteoblasts, I suspect technically yes, but typically it doesn't with a keratosis obturans. This global widening of the ear canal typically is permanent. And if they've got substantial widening of the ear canal as a result to keratosis obturans, they're more prone in future to get a secondary keratosis obturans forming, because whenever you've got an abnormal shaped ear, it's just more harder for the skin to naturally migrate. So if you've got, with a mastoid cavity, for example, if you've had the bone behind your ear removed surgically, sometimes there's a procedure called a radical mastoidectomy, where not only do they drill out the bone behind your ear, but they also drill out the bridge between the ear canal and the mastoid bone, which forms a huge cavity. And when you've got a huge cavity, it's very difficult for the skin to naturally migrate out of the ear. So with those patients, they have to have their ears cleaned on a regular basis. Sometimes it could be 6 monthly, sometimes yearly, or every 2 years, for example. And similarly, if you've got a widening of the ear canal, it just makes it much harder for the skin to naturally migrate. So they have a chronic buildup now. So with this patient, for example, I've advised them to re-attend in a year, even if they have no symptoms, because we just want to re-examine the ear. I've got no doubt there is going to be some level of dead skin accumulation occurring. So we don't want to leave it until this late. And bless this patient, had excruciating pain prior to attending. They weren't able to sleep last night. They took some pain relief this morning prior to attending. And I had to be honest with the patient. I said, it will be slightly uncomfortable with me removing this because you're already experiencing otalgia. You already have got some earache. So it's only once I remove it, hopefully your symptoms will be alleviated. And they were so good, honestly. As an audiologist, I'm not able to instill any anesthesia. Now, there is some form of drops called clear relief drops, which contain some lidocaine, which I did put a bit in, but it's just not, because it's available over the counter, the amount of lidocaine really is just not going to really be helpful, but I still put some in just in case. Now, they have got, now this patient, this is technically a grade 1, although they have got extremely severe otalgia. Fortunately, there was no global widening of the ear canal. Now, I have to be, I want to make it clear, so with the keratosis obturans, it's not an erosion of the bone, like with a canal cholesteatoma, which I discussed a few videos ago, or a benign osteonecrosis, where the bone actually is decayed, it's diseased, and it's breaking down. So it's not a necrosis of the bone, it's simply a remodeling of the bone. And with the keratosis obturans, you shouldn't have any ulceration. The epithelial skin should still be intact. With a canal cholesteatoma, quite often, especially if it's a stage 2 and above, you do get an ulceration of the skin. With a benign osteonecrosis, you don't get a global widening. Or with a benign osteonecrosis, it's not technically a widening, it's an erosion. The bone is actually decaying and dying due to a lack of blood flow. But with a benign osteonecrosis, this widening almost always exclusively happens at the floor of the bony part of the ear canal. And with a benign osteonecrosis, quite often the skin is still intact, but you can get some cases where, like a canal cholesteatoma, there is an ulceration. So a keratosis obturans, a benign osteonecrosis, and an external auditory canal cholesteatoma, they can sometimes be very hard to differentiate in their diagnosis. Now, this patient has what I call a pseudo widening of the ear canal. And what I mean by that, another hallmark of keratosis obturans that you get some inflammation, some swelling in front, so laterally of the epidermal plug. And on the left-hand side in particular, there is some swelling there. And it creates a false illusion, therefore, that this patient's ear canal beyond the swelling is widened when it in fact it's not. But it still makes it very, very hard to remove. Now, eventually, I'm going to use the right ear pick. Now, the right ear pick is kind of an instrument that I developed specifically actually for cases of keratosis obturans. So the normal manual instruments that we use in the UK at least is an ear hook, a Keratosis or a Jobson horn. Some people also use a Rosen inserter, but the rye pick is something that I developed, and the way I did that, I just got an ear hook and I got a grinding machine, and I started just playing around with it. And then I had a fake ear mannequin, and I put like blue tack there, really compressed it, because with an ear hook, and you're going to see that I'm going to use an ear hook a bit later on. I may have already, but there's a moment a bit later on the video that I use an ear hook, but it just wasn't. It was just the angulation of it, because obviously with an ear hook you've got an L bend. It just wouldn't go over the top of this keratin plug. So the ear pick was actually developed as a result of limitations that I felt are available with an ear hook, and it really does shine through the ear pick here. So it's not an instrument that you probably use on a routine earwax removal appointment, but it's something that with keratosis obturans, and I do a fair few cases of keratosis obturans, that it's my saviour, and it really, really did help me in this procedure. So as you can see with the keratosis obturans, it's not easy to remove. It's one of the most difficult things to remove, and most of my procedures that involve a keratosis obturans are above 20 minutes. It's not one of those you can just go in and pull out, unfortunately. Part of the reason is that this patient is also experiencing pain. So you kind of, I feel bad because, you know, you're in the ear and you know you're not touching the canal wall, you know you're not touching the eardrum, but you do experience pain. And obviously just to reassure the patient on a couple of occasions, and the patient was great, they've seen some videos so they understand. I just played back so at moments where I think they found this part very uncomfortable actually, and I'm trying to bring the epidermal plug off the posterior canal wall, but there's swelling there in front of it. And you may have seen on the anterior canal wall, this keratin plug was so compressed, you can see it there, it's actually gone a bit sore there, and that's not because we've made contact with it, it's just that sheer pressure. So it is a challenging thing to remove because of the consistency. It's so elastic, because of all these skin ribbons that are formed and they're still interlocked, they form kinetic energy. So every time you're trying to bring it off the canal wall, you can feel the resistance. It just wants to compress back again. And the patient could actually feel that during the procedure. They were saying, I can feel you're bringing it inwards off the canal walls, but I can feel that pressure of it trying to come back. Now I've put a lot of drops in here. So olive oil drops, which is what the patient used, isn't really going to help with the keratosis obturans. It's not really even going to soften it. So it's not absorbed by the skin cells. So here you do have to use a water-based drops. So I use sodium bicarbonate. So because it's full of keratin and dead skin, the dead skin is hydrophilic. So it actually absorbs the water within the sodium bicarbonate drops. And what it does, it causes the skin cells to overhydrate, if you like, and defragment, because when the skin cells are overhydrated, they swell and they burst at the membranes. It had minimal effect. I did put it in for about 10 minutes, but it didn't really help. But I obviously put some drops in anyway, and I think I put a bit more in here. So we used some drops. I've used every instrument so far. I've used suction. I think I've used some forceps already. I've used an ear hook. I've used a pick. Initially, I did try and go over the top, but it just cut through it. Then I went through the middle. I thought if I make an incision through the middle of the plug, I can then start bringing the keratin plug inwards from the canal walls. There's a space there. So if you've got this big plug and you're trying to bring it in, the core of the plug is going to prevent the peripheral skin from being dragged in. But if you make an incision in the middle, you make an opening, but it didn't really work. So again, I'm just going to the top of this. You can see this ear canal because it is swollen as well. It's really, really narrow. It's elongated, but it's just stuck in there. Another thing, another analogy I sometimes use, it's like chewing gum. It's got that consistency. So I know a lot of people are like, oh, just go in there, get it out. But it's not as easy as that. And believe you me, if it was, I would want to do that for the patient. So which, again, because of the swelling, another thing, because you've got this swelling lateral to the plug is larger than the portion of the ear canal that's directly in front. So you're having to drag this through a narrowing. So here I've tried, this is the moment I refer to, I'm trying to use the ear hook to go, there's no other way, this is not going to come out any other way. And although I used the pick earlier in this portion, it just cut through, but this is why the pick is so good for these cases. I can glide into the smallest, even if there's not a space there, I can create a space. And this keratin plug is so strongly adhered, and I was hoping the ear pick wouldn't give way, but you can see just how strong it is. And I've brought it out, so I've released the pressure. At this point, the patient had a moment and it's almost tearful because their pain and oral fullness that they were experiencing was instantly resolved. Now, although it's not fully out of the ear, this plug, it's still there, but it's kind of released itself. So all that pressure's gone. The patient, even at this stage, could hear so much better. So now I've just gone back to microsuction. We're going to bring this through. There is a second plug, a bit deeper once I remove this first plug. And again, I had to use the ear pick to try and release it. So that's plug number 1. So we're just going to go back in. And that came away without much problem, but I still can't fully visualize the eardrum. And this is still quite stubborn to remove. You'll see it because it's larger than the portion of the ear canal that's lateral to it. So we're still having to squeeze this through. And we want to do all this without making contact with that pressure sore on the front part of the ear canal. We don't want to touch the swelling because that would be uncomfortable. I had to use the full Zollner, the standard Zollner with an outer diameter of 2.1 millimeters because a fine end is just not going to be powerful enough for this. And this is that white peripheral silvery matrix, which is very common with Keratosis obturans. So this is the outer layer of skin that's just freshly shed. And eventually this peripheral silvery matrix will be replaced by another layer of dead skin, and this will be forced more and more into the core. That's why this plug gets bigger and bigger and bigger. You can see it's just stuck here. And you can, on the left hand side of the ear canal where the swelling is, this plug is beyond that swelling. So again, I'm going to use the pick. I didn't use the pick just to, it didn't fully extract, I just brought it through this narrowing and I went back with the microsuction to finally remove it. I think I do have a still image, I'm pretty sure I do, so I will upload that at the end of the video for you guys as well. So again, just trying to bring this through. When I was bringing it through, they did find it slightly uncomfortable because it was rubbing against the swelling and that sore patch on the anterior canal wall. And it's to the left there where it's trapped. So I'm trying to give a little wriggle movement. I also tried lifting it up and reorientate it, but it wasn't coming through. So I think I'm going to use the pick, we shall see. There we are. So I'm just enough just to bring it through, and then I'm going to go back in with the suction probe to fully release this. So I believe this patient's the width of this ear canal, because of the swelling, it should be double what it is. But because of the swelling, it's obviously from the side canal walls, it's come in. So that's the patient's eardrum. You've got this skin already forming very deep in the ear, so I want to peel some of this away. So I'm just dilating and distending the entrance of the ear canal. I'm now going to use the fine end because we're going deeper in the ear. And we're just going to start peeling away some of this. Patient again did find this slightly uncomfortable because obviously their ear is sore, but they were happy for me to try and remove as much of this dead skin around the edge as possible. I couldn't put the endoscope in too far because any further it's probably going to touch that swelling, so I probably should have used the zoom feature to come to I kind of forgot, if truth be told, so I just had the endoscope just a bit further out. I'm so used to, with the previous app I used to use, not having a zoom feature where I'm in the you have to get into that routine almost to remember, but the zoom would have been really, really good because it just means I can have the endoscope a bit further out away from the swelling, but I still get the visual. So I'm really happy with that. I think there's a little bit more that I'm going to get here. There was a bit of clarinetting if I remember, so we did stop, so I didn't get all of it out, but I've got the majority out. There we are, so I'm really pleased with that. So I'm going to put a still image for you guys, and here you are. And so I really hope you enjoyed that video, guys, and you learned a lot more about Keratosis obturans. And keep well and speak soon. Bye.